Now we have very limited time. Now I invite Dr. Soumya Narayanan, orbit and oculoplastic surgeon, Calicut. Another challenging symptom that we come across, diplopia, approach to diplopia.
Good evening all. My topic is approach to diplopia. Diplopia can be worrisome for both the patient and for the physician. And by definition, diplopia is the simultaneous perception of two images of a single object that may be displaced in any direction. Before going to the evaluation of diplopia, we should have a clear knowledge about the probable etiology for a diplopia. Sometimes it can be monocular or binocular. Monocular, the lesions can be local, like intraocular causes. Binocular, the lesions can be at the level of supranuclear, nuclear, internuclear, infranuclear, or at the level of muscle or neuromuscular junction. Monocular diplopia is when the two images are viewed by a single eye, and it's mainly due to refractive or media abnormalities like uncorrected astigmatism, corneal irregularities, tear film abnormalities, iris defects, cataracts, or macular disease. Usually it will improve with pinhole, and when patient is having monocular diplopia and we are not finding any of the reasons, we should think of a primary or secondary visual cortex disease. That time we will call it as a cerebral polyopia. Binocular diplopia are most common, like 89%, where the reason is ocular misalignment, where one image is formed in fovea of the eye and other image is formed in the extrafoveal site of the other eye. During an evaluation, we should get the idea about what is the type of the diplopia, whether it is vertical, horizontal, or oblique, and whether the diplopia is worse in which gaze, near or distant. Is there any corrective head position? What is the temporal progression, whether the patient is having diplopia intermittently, constant, or is there any diurnal variation? And what are the associated symptoms, and whether the patient is having any systemic disease. So these are the three key important examination to rule out the cause of diplopia, that is the extraocular movement, Hess and diplopia charting, and ocular alignment test. So for extraocular movements, we should check for ductions and versions in all 9 diagnostic positions of gaze. We should check for pursuits and saccades. And for ocular alignment, we should check for cover uncover test, alternate cover test, and we should quantify with the prism bar cover test. We should do Maddox rod, double Maddox rod, and PAR 3 tests for vertical tropias. Diplopia charting and Hess charting will give us an idea whether we are dealing with a paretic cause or a restrictive cause, and we should also will get an idea which muscle is lacking and which muscle is overacting. So with all these tests, we will come to a conclusion whether we are dealing with a committant or incommittant strabismus, whether we are dealing with a decompensated phoria, or if the reason is a accommodation or convergence related problem. So in about incommittant diplopias, the one entity is the nerve palsies. Either it can be third nerve palsy, sixth nerve, or fourth nerve palsy, where the most common cause is ischemic. But there can be some hidden life-threatening conditions like compression due to aneurysm or tumors, especially in case of pupil involving third nerve palsy. And in case of isolated sixth nerve palsy, we should also check for increased ICT, where sixth nerve palsy is a false localizing site. Sometimes the unilateral third nerve palsy will present with a bilateral ptosis. Then the lesion will be nuclear level. And also for sixth nerve palsy, where is a ipsilateral gaze palsy associated, we should think of nuclear reason. Sometimes there will be multiple cranial nerves involvement like 3, 4, and 3, 4, 6 along with the ophthalmic branch. So the lesion can be in the superior orbital fissure. And along with that, if there is optic nerve involvement, the lesion can be at orbital apex. And when the cavernous sign is the culprit, there can be 3, 4, 6 involvement along with variable involvement of the trigeminal nerve and sympathetic plexus involvement. So all these syndromes, the reasons can be little dangerous like tumors, vascular causes, infiltration, trauma, infection or inflammation. So in that case, we should definitely do a imaging, either CT, MRI angiogram or venogram. So the other indications for imaging are pupil involving third nerve palsy, non-resolving ischemic palsies, progressive and evolving nerve palsies, painful ophthalmoplegia, and signs of any regeneration. So when we are getting an ocular motility defect and it's variable, And if there is a diurnal variation, we should definitely suspect Mycenia gravis or botulinum toxin. And if there are orbital and lid signs suggestive of thyroid disease, we should check for we should do other investigation to rule out the thyroid disease. And sometimes it can be due to trauma, where it can be either due to entrapment of the muscle or because of the direct injury or because of fibrosis. And also we should have in mind about the orbital causes like myositis and orbital tumors. So with this, we will be able to cover most of the causes, but still we are not in a position to tell what is the cause of diplopia. We should think of supranuclear lesions and internuclear lesions. In internuclear reasons, the lesion will be at the level of MLF or at the paramedian pondent reticular formation defect. So in case of MLF, there will be adduction of the adduction defect of the ipsilateral eye, and when there is ipsilateral MLF and PPF is involved, it's called the 1.5 syndrome. Along with, if there is a seventinal palsy, it's called the 8.5 syndrome. And there is a vertical or horizontal gaze palsy, along with which is not overcome with the help of a head maneuver, that's suggestive of a supranuclear cause. That is, the main reasons are progressive supranuclear palsy, Parkinson's disease, Parinaud syndrome, and skew deviation. Sometimes few drugs will produce diplopia, so we should also keep in mind about the drug history of the patient. And the take-home message is finding the etiological cause is the key in diplopia management, and we should never miss a dangerous diplopia that is causing by a life-threatening condition. Thank you.
Thank you, Dr.